Thank you, Martin, and please just let me know if you can't see my slides. Thank Sandoz for the sponsorship of my session. I have no conflicts of interest, and thank Barry for inviting me again to speak to this audience. My subject is on PCI or CABAG for stable coronary artery disease. And if you look at the slide on the left, the natural history of survival is much worse as the severity of coronary artery disease increases. So the annual mortality is 1.4% for single vessel disease. But when you get to three vessel disease with a very tight proximal LAD, you've got much higher significant mortality. Importantly, on the right side of the screen, you'll see this graph or this diagram illustration, which actually is a very important diagram to explain one of the possible advantages of coronary artery bypass grafting compared to percutaneous intervention, where you see the stent would deal only with the flow limiting lesion and not have any attention to the non-flow limiting lesion, although you would have them on medical therapy to deal with that. Whereas the bypass graft in this case is the left internal mammary artery, would bypass both the flow limiting lesion and the non-flow limiting lesion, the soft plaque, which is more prone to infarction. Importantly, the benefit of complete revascularization appears independent of the treatment modality. That means whether you do PCI or CABAG, you've got to aim for complete revascularization to minimize residual ischemia, which has been shown to be related to mortality. But overall, the best strategy for an individual must take into account the clinical presentation, the comorbidities, the extent and complexity of the coronary artery disease, as well as I think you'd add an extra one, which is the expertise in the various departments in the hospital that you work. The syntax score is a very important score that is used commonly, and this is in the area of the greatest controversy. Patients with left main coronary artery disease or multi-vessel coronary artery disease, the syntax score was prospectively used in the syntax study and graded anatomical severity. On the right of the screen, you'll see it graded according to whether the right coronary artery was dominant or the left coronary artery was dominant, according to where the PDA came off. But it had a number of different criteria for giving the score, and you can see it's graded with a weighting factor, the red 5 being the left main and distal in the LAD being a much lower grade. And this score was then divided into 3 tertiles, dividing patients with a score of 0 to 22, more than 22, and then up to more than 32 into low risk, intermediate, and high risk scoring. And importantly, when you consider the decision between bypass surgery and PCI, complete revascularization should be prioritized, because when you see with more complex disease in the intermediate score and the high syntax score, bypass surgery has a much greater survival rate than PCI in patients with more complex multi-vessel disease. Importantly, it's similar in the low risk score. So let's look initially to the left of the screen on the top, the left main coronary artery stenosis. Here it's relatively simple left main as opposed to this left main, which involves a proximal LAD. And we look at whether bypass surgery or PCI is indicated. And here I'm quoting the European guidelines. In low syntax score with left main disease, they are equal, PCI or CABAG. That does say in the guideline that to intervene on left main in PCI should have at least experience of 25 cases a year, which is important. But when you have left main disease with either intermediate score or high risk score, bypass surgery has a class 1 level A indication. Where you get a very high score, more than 33, and left main disease, PCI is so-called contraindicated, and in the intermediate group is you may do PCI with left main and moderate disease. When you look at 3 vessel disease, and this is the picture on the top right of the screen, LAD, circumflex, and right coronary artery stenosis, and the patient has no diabetes, they're equivalent with a low score. But when you get to the intermediate or high risk score, then surgery is better than PCI intervention. So 3 vessel disease, no diabetes, score above 22, surgery wins. When you look at 3 vessel disease with diabetes, Their surgery wins again, whatever your score. But if you're diabetic with a low score, you may consider 2B means may and not sure. So essentially in multivessel disease with intermediate or high risk scores, and especially in the diabetic, you would go for surgery. However, they do say in the guideline where you saw it was contraindicated in those three spaces that the PCI can be considered if the heart team is concerned about the surgical risk or if the patient refuses CABAG. So it's not a complete contraindication. And I want to give you the most up-to-date data, which is published simultaneously in NEJM and presented at TCT on the 4th of November. This is the FAME-3 trial, which was the fractional flow reserve PCI guided trial, which on the basis of these previous studies, which demonstrated improved outcomes, as I've just shown you, with CABAG compared to PCI, there was a criticism that maybe the stents used in the PCI arm were either bare metal stents or the first generation drug-eluting stents. And the other criticism was that they didn't do FFR, they didn't do physiological testing to say this was a tight lesion, or the mild one that they left was actually a tight lesion. So the FAME-3 trial was in patients with three-vessel coronary artery disease, FFR-guided PCI with the current generation drug-eluting stent, and they wanted to see if PCI in this scenario was non-inferior to bypass surgery with respect to 1 year 4-point MACE. And the study involved syntax scores across the board. But if you look at it, the low syntax score was at least a third involved in the trial. The intermediate were half, and only 18 to 17% were the high risk scores, which would tend to favor PCI. The result, however, is quite stark. PCI did not achieve non-inferiority. It's a double negative. Did not achieve non-inferiority compared to bypass surgery at 360 days. And this is for the endpoints of death, MI, stroke, or repeat revascularization. And the headline is PCI fails to demonstrate non-inferiority to surgery in three-vessel coronary artery disease. I think a very important study. Let's come to the single vessel disease, which is the LAD in this point, particularly outlined on top, and bypass surgery. And you can see with one vessel disease or two vessel disease, PCI is supreme, gets class 1 indications, whether it's an LAD stenosis associated or no LAD stenosis. But when you do have an LAD in single vessel or double vessel disease, there is a class 1 indication as well for surgery. What isn't discussed in the guidelines is redo revascularization. That means the patients had prior CABAG, and these are the mortality rates in Japan of primary CABAG. And then a couple of years later, maybe 10 years later, they have revascularization issues. And this is the mortality with redo CABAG. So this is a time, if you've got a patent left internal mammary and you've got a occluded graft to an obtuse marginal, where PCI may be superior. In the guideline, it does say that if there's no lemur to the LAD and you need revascularization, then an IMA should be placed with a class 2 1A recommendation. And if the patient doesn't have a lemur and goes for bypass surgery, they certainly need to have a lemur attached. Women are an issue because the trials are always stacked against women. Men are mainly in the trials. They're less likely to receive guideline recommended revascularization, less likely to receive complete revascularization, and less likely to receive multiple arterial grafting. And there's a trial plan called Roma, which will be looking at that issue. Patients with heart failure, and this is the Stitch and Stitches trial out to 10-11 years, bypass surgery in the setting of EF less than 35% or with symptomatic heart failure, no matter how bad the viability is, was better with bypass. We are awaiting the PCI trial. So the advantages and disadvantages of bypass surgery versus PCI are pretty stark. Clearly, with PCI, it's less invasive. There's no scar, short hospitalization. Patients prefer it, and CABAG is more invasive with a scar. But certainly, bypass is important in heart failure, a history of patients who cannot take anticoagulation. As opposed to patients with PCI, it's certainly preferred in acute coronary syndrome, severe pulmonary disease, and dementia. The question we don't ask in between these two choices of PCI and CABAG is the possibility of medical therapy. And this is the ischemia trial, which had a lot of LAD in it. They had multivessel disease that weren't left main. There was bypass surgery, 92% getting Lima, the majority with the LAD getting a drug-eluting stent. And there it was found that medical therapy compared to either PCI with latest stents or CABAG surgery, there was no difference between optimal medical therapy. The only important thing was that angina was better treated with invasion, especially in patients who are very symptomatic. So this medical therapy equivalent to interventional therapy was not applicable to the ACS less than 2 months or the highly symptomatic patient or the left main patient. Sorry for Dr. Jankelo talking. PCI and CABAG less than a year and ejection fraction less than 35% or class 4 heart failure and significant renal dysfunctions. And this medical therapy doesn't apply to that group. So in conclusion, multivessel disease or diabetes and multivessel disease and non-emergent coronary disease strongly support CABAG. The threshold for considering CABAG is much lower in the diabetic. In single vessel disease, double vessel disease, PCI is preferred. By patients, PCI is preferred, and optimal medical therapy is effective in mild angina, moderate to severe ischemia, and preserved LV with no left main. Thank you.
Thanks very much, Eric. Eric, can you just go back to that last slide, because we don't have much time for questions. And the one where you said PCI is recommended for multivessel disease.
That is purely on what's happening in the world. That's what's happening in the world. It's not a guideline.
Yeah. So it's not a recommendation. It doesn't follow guidelines, but it's what happens in practice.
Right. Because of patient preference particularly, but also bias from the cardiologist, also bias from the cardiologist.
Exactly. I think we've got to be realistic. The data all supports that the vast majority of patients with multivessel disease and chronic coronary syndromes should have optimal medical therapy and, when indicated, surgery. The role for PCI in those patients is very limited in theory, but in practice,
the syntax, except the syntax 20 less than 22 non-diabetic.
In the non-diabetic, exactly, which is a very small part of that population. Sure. So even in a study which was biased to be in favor of PCI, surgery came out ahead. So the data is overwhelming. The behavior of the cardiologists, whether it's patient preference or cardiologist's preference, are getting an inappropriate therapy. And all I can say is, because we've got to go on to the next talk, is that yet again, we're seeing studies, ischemia in this instance, where the mortality benefit of surgery is said to warrant further investigation. So I'm going to leave you with this. If you, as a cardiologist, want your patient to do well for 1 month, PCI is better than surgery for multivessel disease. If you want them to live, or their life expectancy is more than 1 month, for the vast majority, surgery is the modality of choice. Eric, any comments before we...
No, look, I wouldn't say it as vehemently as that, but it clearly shows that bypass surgery has a significant role in multivessel disease, especially in the diabetic.
Eric, that really was a superb presentation of a complex subject, and I thank you and hand you over to the next chairperson. Thanks.